Question 1. A Pacemaker valve or PMV is one way speaking valve used by patients who have a tracheostomy tube. It is it's designed to restore a more normal pattern of breathing and allow the patient to speak. Here's how it works. The valve attaches to the outside opening of the trach tube. It opens on inhalation, allowing air to flow into the lungs through the trach tube as normal. But on exhalation, the valve closes, which redirects the exhaled air up through the vocal cords, through the mouth and the nose, instead of out through the trach tube. This is what allows the patient to produce sound and speak. It also helps restore subglottic pressure, which can improve swallowing function, secretion management, and a sense of smell, since air is moving through the upper airway again. Candidates for a PMV are typically patients who are alert, can tolerate cough deflation, and have some ability to manage their own secretions. It's commonly used in patients who are trached but no longer ventilator dependent. Before placing the valve on the trach tube, the RT must absolutely be sure the cuff is fully deflated. This is the single most critical safety key. If the cuff is still inflated when the valve is placed, the patient will have no pathway for exhaled air to escape at all. They can inhale through the trach, but they have nowhere for that air to go on exhalation, since the inflated cuff blocks the upper airway route and the closed valve blocks the trach route. This creates a dangerous, potentially fatal situation of air trapping and inability to exhale. So the cuff deflation is mandatory and must be confirmed every single time before the valve, is applied. Question 2. A tracheostomy is a surgical procedure in which an incision is made into the trachea, typically below the level of the cricoid cartilage, to create an opening directly into the airway. Once that opening, called a tracheostomy, is created, a tracheostomy tube is inserted to keep the airway open and to allow for ventilation, suctioning, and airway access. There are several indications for this procedure. One of the most common is the need for prolonged mechanical ventilation. Generally, if a patient is expected to need an artificial airway for more than 1 to 2 weeks, a tracheostomy is often preferred over a long-term endotracheal tube because it reduces the risk of laryngeal and tracheal injury, improves patient comfort, and can reduce sedation needs. Other indications include upper airway obstruction, such as from tumors, trauma, or severe swelling, which makes it impossible to pass an endotracheal tube through the mouth or nose. It's also used in cases of facial trauma or congenital airway abnormalities to bypass an obstruction at or above the level of the larynx to help patients who have difficulty managing their own secretions or have an inadequate cough and need easier access for suctioning. Now, to answer the second part, does a tracheostomy tube go through the glottis? No, it does not. This is actually one of the major advantages of a tracheostomy compared to endotracheal tube. An endotracheal tube passes through the mouth or the nose, down through the pharynx to the glottis, meaning between the vocal cords, and into the trachea. The tracheostomy tube, on the other hand, is inserted directly into the trachea through a surgical opening in the neck below the vocal cords. Because it bypasses the glottis entirely, it avoids the risk of vocal cord injury and laryngeal damage associated with prolonged intubation. Question 3. Endotracheal tube cuffs should be maintained at a pressure between 20 to 30 centimeters of water. The goal is to keep the pressure within this specific range using a manometer. The reason this range matters so much comes down to balancing two competing risks. If the cuff pressure is too low, below about 20 centimeters of water, the seal between the cuff and the tracheal wall isn't tight enough. This allows air to leak around the cuff, which can lead to inadequate ventilation, loss of tidal volume, and it also increases the risk of aspiration. Secretions, especially oral secretions, sitting above the cuff can leak down past a poorly sealed cuff and into the lower airway, increasing the risk of ventilator-associated pneumonia. On the other hand, if the cuff pressure is too high, above 30 centimeters of water, it can compress the capillaries in the tracheal mucosa. The tracheal wall has a limited blood supply, and the excess pressure can cut off that circulation. Over time, this can cause tracheal mucosal ischemia, which can progress to tissue necrosis, ulceration, and in severe or prolonged cases, complications like tracheal stenosis or even tracheoesophageal fistula formation. So maintaining that 20 to 30 centimeters of water range is really about protecting the airway from two different but related harms. Underinflation leading to leaks and aspiration, and overinflation leading to tissue damage. This is why routine cuff pressure monitoring is such an important part of standard care for any patient with an artificial airway. Question number 7. FEV1 stands for forced expiratory volume in 1 second. It's the amount of air a person can forcefully exhale during the first second of a forced expiration after taking a full breath in. It's measured using spirometry. The patient takes a maximal inhalation, then exhales as forcefully and completely as possible into the spirometer. This device measures the volume of air exhaled specifically within that first second, which is reported as the FEV1. This is almost always measured alongside FVC or forced vital capacity, which is the total volume exhaled during the entire forced breath. Together, these two values are used to calculate the FEV1 divided by the FVC ratio, which helps distinguish between obstructive and restrictive lung diseases. A normal FEV1 value is typically expressed as a percentage of predicted based on the patient's age, height, and gender. Generally, FEV1 of 80% or more of the predicted value is considered normal. Values below that threshold can either can indicate, obstructive diseases such as COPD or asthma. Question 12. VALI stands for ventilator associated lung injury, and there are 5 recognized types: barotrauma, value trauma, atelectic trauma, biotrauma, and oxygen toxicity. The first is barotrauma. This refers to lung injury caused by excessive pressure, specifically high transalveolar pressure from mechanical ventilation. This can cause alveoli to rupture, leading to complications like pneumothorax or subcutaneous emphysema. This is why we monitor and try to limit plateau pressures during ventilation. The second is value trauma. This is closely related to barotrauma, but the injury here comes specifically from overdistension of the alveoli due to excessive tidal volumes, rather than pressure alone. When alveoli are stretched beyond their normal capacity, the lung tissue itself becomes damaged at a structural level. This is part of why lung protective ventilation strategies emphasize using lower tidal volumes, often around 6 to 8 milliliters per kilogram of ideal body weight. The third is atelectic trauma. This type of injury results from the repeated opening and closing of alveoli during the ventilatory cycle. When alveoli collapse at end expiration and then are forced back to open with each breath, the shearing forces from that repetitive collapse and reopening damage the alveolar epithelium. This is why adequate PEEP is so important. The fourth is biotrauma. This refers to the release of inflammatory mediators like cytokines in response to the mechanical stress placed on lung tissues from the other injury types. This inflammatory response can stay localized in the lungs, but it can also become systemic, potentially contributing to multi organ dysfunction. And the fifth is oxygen toxicity. This results from prolonged exposure to high concentrations of supplemental oxygen, generally an FiO2 above 60% for extended periods. This high oxygen exposure can lead to formation of reactive oxygen species, which damage lung tissues and can also contribute to absorption atelectasis.